the first recipient of insulin. It caused severe allergic reaction. Even after 100 years of its use, insulin has its problems and its everyday use is associated with several mistakes. I'm going to talk about those and how to address those under the following headings. India has a very high prevalence of diabetes mellitus. In this population of India, about 15 to 20% use insulin. I'm going to navigate through a case vignette about Mrs. X, a 45-year-old housewife who visited the OPD of a government hospital with uncontrolled glycemia or hyperglycemia. These levels of blood glucose warranted the use of insulin. At the very beginning, there are certain stakeholders in the administration in giving and in receiving insulin. Who are those? The patient, the physician, and the pharmacist. For the physician, the easiest work is to give a prescription. However, the prescription should be done after assessing clinically and also the environmental and socio-cultural aspects of the patient. This is one example. The insulin regime, the dose of insulin, the route of insulin administration, the timing of insulin is mentioned, but there are mistakes. Apart from this, the insulin delivery devices is something which is often in prescriptions. So this is often the first mistake. The second stakeholder, the patient. Whenever the information about insulin was given to Mrs. X, she thought, okay, this is the end of my life. I'm afraid of needles. Why? Because it is often perceived as a sense of loss of or a sense of personal failure, a perceived loss of control over life, but more importantly, that she has been unable to control the disease, so it has progressed to such a stage that it requires insulin. These are all misconceptions, and this fear needs to be allayed. So darna not only mana hai, but dar ke aage jeet hai, that has to be conveyed to the patient, and that requires timing, time to be spent with the patient, counseling. So all misconceptions can only be removed if this is addressed. Now, insulin has its various types. It has various formulations. It comes as premixed, it comes as the short acting, rapid acting, long acting, intermediate acting, ultra long acting. They're packaged differently in vials or in cartridges, and they are delivered either through the syringes or through the. Now, when we are talking about the concentration of insulin, we need to remember 100 IU per ml comes with the orange color tag, the 40 IU per ml with the red color tag. And because we are talking in Punjab, we should know what is going on in India also, probably. So I'm talking about the 500 IU per ml, which is not there in India at this moment, but it has come in the Canadian guidelines and the FIT guidelines in Canada also. So the green one, orange one, and red one, but the colors are specific. They cannot be interchanged. Otherwise, dosing inaccuracy can happen, and it could result in abnormal glycemic control. Insulin could be clear, or it could be cloudy, or it could be damaged in the form of precipitation, lumpy, or frosted insulin. However, if it's working and it's fine, if it's cloudy, the concentration needs to be uniform, and for that, resuspension needs to be done by rolling or tipping 10 times. One important funda which cannot be forgotten in case of insulins when they have to be mixed. There is a split mix regimen. Over there, remember that clear insulin has to be taken prior to the cloudy insulin. That is, the regular insulin has to be mixed, has to be taken in the syringe first, and then only the cloudy NPH can be taken. There are preparations like premixed, but they come in a ready-made variety. Once Mrs. X about taking insulin, she had to think about how to store it. The classical teaching is, when not in use the refrigerator at 2 to 8 degrees centigrade. If it's in use, then it can be kept up to 1 month at a temperature up to 25 degrees centigrade. Yes, that was in the olden guidelines. But the new guidelines haven't come, but evidence has definitely come from the Cochrane Library. And this is to be remembered because it is beneficial for patients in India with varying temperatures across the country, that these vials or cartridges could be kept for a period of 6 months at a temperature of 25 degree or up to 37 degrees for a period of 2 months. So it brings a lot of more months into the picture, and oscillating temperatures won't damage the insulin activity. Insulin injection. For lack of time, we are discussing only the pen device and the syringe. And why also so? Because that's most commonly used by patients across the country. There are multiple steps of administering insulin, but 2 steps I would like to highlight from both the insulin syringe use and the pen device. That is, after usage, the needle has to be kept within the subcutaneous tissue. That is, after the insulin is fully plunged out with the plunger, the needle should be there with the subcutaneous tissue for at least 10 seconds. Also, the angulation of the device is important. Why so? Because the needle size determines it. One more important aspect which should not be forgotten is never leave the needle attached to the pen, because air can enter which could contaminate the reservoir, and also doses might be altered. Plus, when it's hot temperature, there could be insulin leakage from the cartridge also. A study done in central India observed the different routes of administration or different sites of administration of insulin. Most importantly, one should remember, abdomen preferred, the thighs preferred over the arm, but same side should not be selected. It should be rotated. For the abdomen, the umbilicus is the landmark, 2.5 centimeters above and below, 5 centimeters maybe laterally. Anything which is outside, it can be divided into a square with 4 parts or 4 quadrants. And remember, 1 quadrant to be used per week and same site not to be used for any injection. Insulin administration always does not require a skin fold. However, if the needle is longer than 5 millimeters according to some resources or 8 millimeters, then a skin fold might be necessary before administering insulin. And why is that? The purpose of insulin administration of the needle should be in the subcutaneous tissue. Why the subcutaneous tissue? Because it has a uniform blood flow. The other parts, that the epidermis or the muscular tissue, they have erratic absorption, and therefore subcutaneous tissue is the choice of insulin injection. This insulin injection could be associated with pain, bleeding, bruising, or something known as lipohypertrophy. Why do this happen? They can happen due to the needle length. 1, 1, 1, not the triple Nelson or not one election. We are talking about 1 person, 1 needle, 1 use. Ideally, it is that. But remember, these are derived from the Western guidelines. It is also written, it's ideally. However, in India, due to cost constraints, it may not be the actual picture. And therefore, the problems or the mistakes which happen in the common everyday use could arise. One thing to remember out here is, use the shortest possible needle. So if it's a pen device, a 4 millimeter needle. If it's a syringe, use a 6 millimeter needle, because our target is subcutaneous tissue. Now, how to make this injection less painful? One of the biggest reasons why people are afraid of giving from the doctor's side, or people receiving it from the patient's side. This could be done by avoiding all these techniques which could cause intramuscular injection, or using 1-1-1 formula as I've mentioned, or using shorter needles, and also putting the plunger in properly without the insulin getting wasted. So these are some of the methods by which the pain could be reduced. However, there is a new concept not available in India across all places, is the use of non-posted pen needle. You could look at the picture which is there below, versus the use of a posted pen needle. So the non-posted pen needle is actually associated with less pain because it gets deposited in the subcutaneous tissue as depicted in the lower picture. The 4 millimeter needle size is the ideal, and what we should remember that the insulin injection could be associated with something known as lipodystrophies, either hypertrophy or atrophy. Hypertrophy is of concern because it is related to the repeated needle use which we talked about, or the non-rotation of sites which we talked about, the basic mistakes. Insulin being an anabolic hormone, it causes lumps and bumps over the abdomen which could be palpated. That also requires basic clinical examination. And why is it important in the management? Because it can cause erratic glucose absorption, resulting in fluctuating glucose levels, and therefore the outcome may be directly related to it. We have heard the glucocentric versus adipocentric, probably something which is coming into the picture over here. Lipoatrophy was discussed previously with annual insulin, especially in women with type 1 diabetes who had an immunological reaction. Remember, this sort of a lipoatrophy, though initially neglected, but this treated with also. Certain institutes go about treating this with steroids, local use of steroids. Now, due to the financial constraints, Mrs. X had to use the needle multiple times. So needle reuse is another mistake which happens, but which cannot be always avoided. Why the problem will happen? Because repeated use will cause blunting. Blunting will cause trauma. Trauma will be associated with pain. Or bleeding or bruising can happen. The needle tip can reside within the or under the skin. Or the most important problem which can happen is that because the needle gets a different shape altogether, and more pressure might be required to push the insulin in. So, whenever the insulin has been used and everything has been done for the patient, not only the patient but also of the people around should be thought about, and therefore it has to be disposed of in a puncture-proof container after cutting it properly or capping properly, or in a rural setup maybe using a cardboard cover or a glass box for disposal. Fasting hyperglycemia. What do we commonly think? Reflex action, increase the dose of insulin. But remember, there is something known as Somogy phenomenon as against the Dawn phenomenon, where treatment is not increasing the insulin dose, but rather decreasing the insulin dose or altering the timing of insulin. Now, a common myth is whenever the patient is kept NPO, stop insulin. No, insulin should not be stopped. There are certain insulins like basal whose dose can be adjusted and which can be used, or the other insulins which could be stopped or could be adjusted. There are certain special populations who require special care. The pregnant women, the elderly, those with sensory and motor impairment, and the immunocompromised. I'll talk about two of them. The elderly. The elderly have cognitive dysfunction, they have dexterity issues, problems. The pregnant women, on the other hand, during the third trimester specifically, have a taut skin over the central abdomen. Therefore, in...
Excuse me, sir, I request you to kindly finish
Ma'am, 1 minute more. So, in the pregnant ladies, the lateral side of the abdomen could be chosen for giving insulin in the third trimester. In the elderly, special care has to be taken. For example, for those who are visually challenged, clicks happen in the insulin pen. For those who have dexterity problems, pre-filled doses could come. However, we should all remember at the end of the day that though we are dealing with someone who has batted for a long time, is well settled, that is a centurion, that is insulin. However, a good ball may bowl him out. And for that, all the methods which we have discussed or all the aspects which we have discussed need to be addressed and continuous training given so that we have improvement in the results of the patients. To sign off, I'll talk about the last aspect which a question came into my mind. A person who is visually challenged with hearing problems, who has challenges with financial problems, which we are all dealing with in a government institute, and also is physically challenged. What about that person if he or she requires insulin and the advances? The question is there. I don't have the answer, and taking a cue from yesterday, probably will find out the answer in the due course of time. Thank you. Thank you for a patient hearing.
Thank you very much for an enlightening talk. We are really